Alopecia. Letter of Referral. Dear Dr. Re. Mrs. Alice Cooper, aged 30 years. Thank you for seeing this 30-year-old woman with a 2-year history of progressive scalp hair loss. She has no significant past medical history. Yours sincerely. Introduction. The first point of assessment is to decide whether her acquired hair loss is diffuse or focal and patchy, and if there are clues as to whether it might be scarring or non-scarring. By placing the nature of her hair loss into one of these categories, the differential diagnoses rapidly narrow. Causes of alopecia: patchy or focal with scarring, lupus erythematosus, lichen planus, sarcoidosis, cicatricial pemphigoid, tumor, e.g. basal cell carcinoma, burns, radiation, secondary to fungal carrion, patchy or focal and non-scarring, alopecia areata, androgenetic, traction, tinea capitis, ringworm, syphilis, diffuse and non-scarring, extensive alopecia areata, anagen and telogen effluvium, iron deficiency, endocrine, e.g. hypothyroidism, malnutrition, chronic disease, drugs. History of the presenting problem. Once it has been established that the patient has an acquired alopecia, then the history should focus on a description of the hair loss, its distribution, and its temporal association with other events. Sudden hair loss, in which the hair may be described as coming out in handfuls, suggests an anagen or telogen effluvium, Table 6, or an extensive alopecia areata. There may be a relationship to major life events in a telogen effluvium, e.g. major illness, trauma, or childbirth. Ask if there has been hair loss from other sites. Are there any symptoms to suggest the hair loss is associated with an underlying skin disease? Is there any itching or scaling of the scalp? Are there any skin problems elsewhere, or any nail or mouth involvement that might suggest lichen planus? Are there any systemic symptoms that might indicate systemic lupus erythematosus? If there is any possibility that the hair loss is due to cutaneous malignancy? Is there a history of significant sun exposure? Are there any features in the history suggestive of excess androgens, e.g. acne and hirsutism, or other endocrine disease, e.g. weight gain and cold sensitivity in hypothyroidism? Does the patient tie her hair back tightly? Tension on the shafts can eventually damage the follicles. This is most commonly seen in black women who tightly braid their hair. Other relevant history. A full functional inquiry should follow, with particular emphasis on features that might suggest anemia or autoimmune disease. The drug history is important, with accurate start dates so that potential drug triggers can be identified or excluded. Ask about the family history, particularly in cases of androgenetic alopecia. Alopecia examination. General features. From the end of the bed, look for signs of systemic disease relevant to hair loss, e.g. signs of thyroid disease and virilization. See Table 5 for causes of hair loss. Cutaneous examination. Androgenetic alopecia. Preferential loss from temples and crown. Other signs of androgen excess in women. Traction alopecia. Usually frontotemporal hairline. History of braiding. Alopecia areata. Patchy hair loss. Normal skin on exposed scalp. Exclamation mark hairs. Maybe pitting of nails. May see hair loss at other sites. Lichen planus. Patchy hair loss. Inflamed or scaling skin on exposed scalp. Involvement of skin apart from scalp, especially the wrists. May have Wickham striae in mouth. May have abnormalities of nails. Tinea capitis. Patchy hair loss. Inflamed or scaling skin on exposed scalp. Usually occurs in children, especially those who are Black or Indo-Asian. May be cervical lymphadenopathy. Discoid lupus erythematosus. Patchy hair loss. Inflamed or scaling skin on exposed scalp. Telogen effluvium. Diffuse hair loss. Normal skin on any exposed scalp. May be Bose lines on nails. Anagen effluvium. Diffuse hair loss. Normal skin on any exposed scalp. Chronic disease/nutritional deficiency. Diffuse hair loss. Normal skin on any exposed scalp. Distribution of hair loss. The distribution of the hair loss can provide early clues to the underlying etiology, e.g. preferential loss from the temples and crown might suggest a diagnosis of androgenetic alopecia. Additional patchy loss from other non-scalp sites would raise the possibility of alopecia areata. Traction alopecia can be patchy, Fig 24, but is usually most marked along the frontotemporal hairline. Alternatively, there may be diffuse hair loss, which raises different diagnostic possibilities such as a telogen or anagen effluvium, and chronic disease or nutritional deficiencies, see Table 5. Morphology of scalp. Is the scalp normal or is there evidence of an underlying skin disease? In alopecia areata and where there is diffuse hair loss, the scalp is normal, Fig 25. In alopecia areata, you may see exclamation mark hairs, broken hairs 3-4 mm in length, tapering and less pigmented proximally. Look for inflammation or scaling of the skin, which may indicate tinea capitis, Figs 26 and 27, lupus erythematosus, Fig 28, or lichen planus. Look for scarring, smooth, shiny skin in which the hair follicles are invisible, Fig 28b. Other relevant examination. Check hair-bearing sites other than the scalp, which may be affected by alopecia areata. Look at the remainder of the skin, the nails, and the oral cavity, where there may be features of an inflammatory skin disease such as lichen planus or lupus erythematosus. The nails might also be pitted in alopecia areata or show Bose lines in telogen effluvium. Are there other signs of androgen excess in females, e.g. acne, hirsutism, and virilization? Further discussion. How would you investigate this patient? This will depend on your suspected diagnosis and your assessment of whether the process is diffuse or focal or patchy, and also whether there is evidence of an underlying skin disease. In some cases, no investigation will be required if there is a straightforward diagnosis from the history and examination. NB. Fungal carrions are boggy inflammatory masses that most commonly occur on the scalp of Black and Asian children, Fig 27. They may be mistaken for bacterial abscesses. Samples should be taken to confirm the presence of dermatophytes and to avoid unnecessary incision and drainage. Plan for investigation and management. In any patient with patchy alopecia, it is important to exclude fungal infection of the scalp with Wood's light examination and microscopy and culture of skin scrapings and hairs. If there are features suggestive of excess androgen secretion, then appropriate endocrine investigations should be undertaken. Other screening blood tests may include hemoglobin, hematinics, thyroid function, and an autoimmune screen including antinuclear antibodies. In the setting of recent severe illness or surgery, an excess ratio of telogen club follicles to anagen follicles on hair microscopy would suggest a diagnosis of telogen effluvium. If there is clinical evidence of scarring alopecia or if the diagnosis is unclear, then it may be appropriate to proceed to a biopsy for histology and immunofluorescence. Further discussion. Clearly, if there are other clues from the clinical assessment or initial investigations that might suggest a specific diagnosis, then more detailed relevant investigations will be appropriate, e.g. full anemia or endocrine workup.